Arizona starting a massive testing effort for antibodies to the novel coronavirus, with plans to test up to 250,000 healthcare workers and first responders throughout Arizona. So joining us to discuss that effort is Dr. Michael Dake, Senior Vice President at the University of Arizona Health Sciences. Dr. Dake, thank you so much for being here with us this evening. Tell us about this massive effort you're about to start and when you expect to see the first results and your hypothesis, if you can give us one at the outset, of what you might find.
Sure, Meg. Approximately 3 weeks ago, we committed to testing all 45,000 University of Arizona students and 15,000 faculty and staff. We developed this test within our labs, research labs in immunobiology and immunology at the university. And once it was developed and validated, we went to the state and said, is there any way this could be of use to you? And then they partnered with us, as you mentioned, to roll out 250,000 tests with a priority to healthcare workers and first responders. That effort will start off this Thursday. We announced today, and people are signing up now online, pre-registering, to go to these individual sites, over 30 around the state, to get tested for. These are serology tests, obviously. They're not nasal swabs to determine the virus, but rather any immunity that people may have conferred after having been exposed to the virus. And this, again, the state has prioritized these two groups because in their mind, these are the ones that I think are maybe the most vulnerable and where we could learn the most about who's been exposed and what the seroprevalence rate is in the state. But it's possible this may go on beyond the 250,000 to other groups of workers.
Tell us about the validation of the antibody test, the specificity, the sensitivity, the reliability of the test, really, and the expectation that you might see false positives or false negatives.
Sure, of course. Well, this test is an antibody test, and it's directed against the coronavirus spike protein receptor binding domain. And we have right now a specificity of 99.7. That gets at the false positive rate, which obviously if you have a very low incidence or seropositive prevalence in a state, if you have a 1% false positive rate, that could result in a lot of those tests that are positive being false. So 99.7 is very good, and we have a sensitivity of 95%. So we're really confident that this test is very accurate. It's a blood test. It's not a point-of-care finger stick. So everyone will have to go to a site and have their blood drawn in a single tube, and the results will be reported out in 48 hours.
In your effort to also test all the 45,000 students at the university and the 15,000 employees, will you make decisions using the results about whether to start things back up, bring students back on campus?
Well, very much we'd like to bring students back on campus. And again, this is just one tool that we'll be using, including potential for sort of self-quarantining a week before students come back. Obviously, the PCR test or nasal swabs or saliva testing, as well as contact tracing. And again, is to try to provide as much information possible to our students so that we can, in the most sensitive way, try to blend groups together, whether it's in a dormitory, whether we can certainly have dorms that are available for quarantine patients who become symptomatic. But it's a very different sort of procedure or concept than what we're doing now with the state. Because we expect for the students coming back, this will be a lot of serial testing. As mentioned by Dr. Gottlieb, there may be an outbreak in the fall. Obviously, we need to be prepared to deal with that. Certainly, if we can ascertain in a serial way what's going on with students in terms of their exposure, because it's very different than out in the general public, that we could use this information to, I think, best keep our students safe.
I was looking at the numbers of testing for current infection, those nasal swabs you mentioned that Arizona's done, about 66,000 total tests. That breaks down to about 890 per 100,000 people in the state. And on a per capita basis, that's among the lowest in states and territories across the country. I saw that state officials were starting this Arizona testing blitz to try to increase that, but do you think that the state just doesn't have as good of a picture of infections there because of that lower testing rate? And will this really enhance that picture?
Well, that's a good question. I'm not really sure. I think Arizona, for the size of its state, has been one of the lowest or in the lower group of actually incidents of COVID-19. These testing blitzes are meant to go through 30,000 individuals in, say, a couple weekends. We're going to be standing up a similar type thing. We've been supplying test kits around the state, the various tribal nations, counties, et cetera, making our own test kits. But we personally are not performing the PCR test to look for the viral particle itself.
All right, Dr. Dake, well, stay tuned for your first results. We're eager to hear them. Thank you so much for being with us tonight. Scott, back to you.
Thank you very much, Meg.
All right, Meg, we appreciate that very much, that of the doctor as well. Dr. Gottlieb, back with us. An ambitious plan in Arizona. Your thoughts on it?
Look, that's the right thing to do. That's a big seroprevalence study. They're going to get a good indication of what the background exposure is to coronavirus in that state. And the test that the doctor talked about, it sounds like a very accurate test. That's the kind of test that you want to deploy to try to figure out just what percentage of people have been exposed to coronavirus. It has a high what we call specificity, so you're likely to get fewer false positives with that test. And what it means is when people do take the test and it says that they have antibodies, they're more likely to actually have antibodies using a test like that.
Can it be replicated more broadly?
Absolutely, but it's a big undertaking. And doing those kinds of seroprevalence studies are big undertakings. The CDC is doing one right now nationally, where they're trying to get a representative sample nationally to get a sense of what the background rate of exposure is across the entire country to coronavirus. We've said on this show, and I still believe that when we do this at a national scale, we're likely to find anywhere from 2 to 5% of the population as a whole has been exposed to the virus. But in hotspot cities like New York, Louisiana, parts of Louisiana, New Orleans, Miami, Chicago, Detroit, you're likely to see much higher percentages. And the data that came out of New York recently showing as many as 21% of New Yorkers may have been exposed to coronavirus. That might be a little high, but it's not too high. It's probably somewhere between 10 and 20% of New Yorkers right now have been exposed to this infection.
So lastly, take the temperature, if you would. Texas and Iowa are getting set to reopen. Other states are certainly thinking about it and formulating their own plans, and they'll put them into practice certainly in the days, if not weeks ahead. Where are we on this issue? How do you feel about the process of reopening our country for business?
Well, look, a lot of the data and a lot of the modeling assumes what we call a symmetric epidemic curve, which is a sharp up and a sharp down. And that was the experience in China. The epidemic grew very quickly and it came down very quickly. And a lot of the models that we're looking at, like the IHME model, are based on the China experience. But what we're going to experience here is much more like what Europe's experiencing, where it was a sharp up, but a very slow, gradual down. And so we're plateauing right now across the country. We're seeing some gradual declines in parts of the country, like New York. But it's likely to be a very gradual decline in the number of new cases. We're still seeing 30,000 new cases nationally, and we're still seeing upwards of 2,000 deaths a day. So while things are slowing and moving in the right direction, it's going to be weeks probably before we have a sustained decline in new cases and a low enough number of new cases in most parts of the country that we really feel confident. Now, certain states are doing better than others, and they are in a position to start reopening parts of their economy. But really, it's just a handful of states that are in that position right now.
Why the difference, though, between Europe and China? Is it a result of the kind of lockdowns and when they happened in those countries?
That's probably the biggest factor. China took much more aggressive steps and were able to implement them in a much more uniform way. And the Europeans and the United States had leakier mitigation steps. We didn't implement them as quickly, and we had more leakage from those steps. We weren't able to do the same things, and we didn't want to do the same things that China did. They had a very harsh response that just wouldn't have been able to be implemented in this country. So we're likely to see a more gradual decline in new infections as a consequence of that.